Skin lesions are classified as primary, meaning the initial, unaltered lesion that first develops, or secondary, which are lesions that evolve from primary lesions or are caused by external manipulation such as scratching or infection. Before identifying the specific lesion type, two fundamental descriptive categories must be noted. First is the configuration, which describes the arrangement of multiple lesions. Patterns include linear, annular, which means ring-shaped, archiform, grouped, or diffuse. Second is the distribution, which describes the body area affected. Terms include localized, generalized, symmetric, asymmetric, sun-exposed, intertriginous meaning skin folds or dermatomal. These features, combined with the primary and secondary morphology, systematically build the differential diagnosis. We begin with primary lesions that are flat. A macule is a flat, non-palpable lesion distinguished solely by a color change from the surrounding skin. It is less than 1 centimeter in diameter. Because it is flat, you cannot feel it with your eyes closed. Examples include a freckle, a flat nevus or mole, and petechiae, which are tiny red spots from bleeding. A patch is essentially a large macule, greater than 1 centimeter in diameter. It is also flat and non-palpable. Examples include the depigmented areas of vitiligo, a port wine stain birthmark, and the hyperpigmented patches of melasma. Moving to primary lesions that are solid and elevated. A papule is a solid, elevated palpable lesion less than 1 centimeter in diameter. It has depth, meaning you can feel it. Examples include an acne papule, a wart, and the pearly bumps of molluscum contagiosum. A plaque is a palpable, elevated, flat-topped lesion greater than 1 centimeter in diameter. It is essentially a confluence of papules or a large, broad-based elevation. Classic examples are the well-demarcated scaly plaques of psoriasis, the violaceous, itchy plaques of lichen planus, and the coin-shaped plaques of nummular eczema. For deeper or larger solid lesions, we have the nodule and tumor. A nodule is a solid, palpable lesion with depth larger than a papule. It is greater than 1 centimeter and often extends deeper into the dermis or subcutaneous tissue. Examples include a firm dermatofibroma, the tender red nodules of erythema nodosum on the shins, and a soft, mobile lipoma. A tumor is a large nodule, typically larger than 2 centimeters. The term often, but not always, implies a neoplastic growth which can be benign or malignant. Examples include the pearly, telangiectatic nodule of a basal cell carcinoma and the keratotic nodule of a squamous cell carcinoma. Now for fluid-filled primary lesions. A vesicle is a small, fluid-filled elevated lesion less than 1 centimeter in diameter. The fluid inside is clear serous fluid. Examples include the clustered vesicles of herpes simplex, the widespread vesicles of varicella or chickenpox, and vesicles seen in acute allergic contact dermatitis like poison ivy. A bullae, commonly called a blister, is a large vesicle greater than 1 centimeter in diameter. It also contains clear fluid. Examples include the tense bullae of bullous pemphigoid, bullae from a second-degree burn, and a simple friction blister. When the fluid becomes purulent, we have a pustule. A pustule is a vesicle or bulla that contains purulent material, or pus. It appears white or yellow due to the presence of neutrophils and cellular debris. Examples include the classic yellow-topped acne pustule, the pustules of folliculitis around hair follicles, and the sterile pustules of pustular psoriasis. An abscess is a localized collection of pus within the dermis or subcutaneous tissue. It is deeper and often larger than a pustule. Examples include a furuncle, which is a deep infection of a hair follicle also known as a boil, and a carbuncle, which is a coalescence of multiple furuncles. Two other important primary lesions are the wheal and telangiectasia. A wheal, commonly called a hive, is a transient, edematous, erythematous or pale papule or plaque. It is characterized by localized dermal edema. It is evanescent, meaning it often lasts less than 24 hours in one spot. The classic example is the lesions of urticaria, or hives, and the immediate reaction to an insect bite. Telangiectasia is a visibly dilated superficial blood vessel. It appears as a fine red line or a web-like pattern that blanches or temporarily disappears when pressure is applied. Examples include the facial telangiectasias of rosacea, the hereditary disorder hereditary hemorrhagic telangiectasia, and the fine vessels seen in chronic sun-damaged skin. We now transition to secondary lesions, which result from the natural evolution or external manipulation of a primary lesion. Scale is an accumulation of excess stratum corneum, which are dead keratinocytes. It appears as flaky, dry flakes or plates on the skin surface. Scale can be fine and bran-like, as in pityriasis, or thick and silvery, as in psoriasis. Other examples include the greasy scales of seborrheic dermatitis and the fine scales of simple dry skin, or xerosis. Crust, also called a scab, is dried exudate on the skin surface. This exudate can be serum, blood, or pus. Crust represents the aftermath of a vesicle, bullae, or pustule that has ruptured or dried out. The classic example is the golden or honey-colored crusts of impetigo, a bacterial skin infection. Crusting is also commonly seen in eczema that has been weeping fluid. Erosion and ulcer represent loss of skin surface. An erosion is a moist, shallow, depressed lesion resulting from loss of the epidermis only. Because it does not damage the deeper dermal structures, it heals without scarring. Examples include the base of a ruptured vesicle, an aphthous ulcer or canker sore in the mouth, and the moist red areas in skin fold intertrigo. An ulcer is a deeper depressed lesion with loss of the epidermis and at least part of the dermis, and sometimes deeper tissues. Because it damages the dermis, it heals with scarring. Examples include a venous stasis ulcer on the lower leg, a decubitus ulcer or pressure sore, and the primary chancre of syphilis. Fissures and excoriations are often related to itching or dryness. A fissure is a linear, crack-like cleavage through the epidermis into the dermis. They are often painful. Examples include angular cheilitis at the corners of the mouth, cracks in the finger webs from hand eczema, and an anal fissure. An excoriation is a linear or punctate erosion specifically caused by scratching. It is direct evidence of pruritus, or itching. Examples include the scratched areas in atopic dermatitis and the linear burrows and excoriations seen in scabies. Lichenification and scar are changes from chronic injury. Lichenification is a thickening of the skin with visibly accentuated skin markings. It is caused by chronic rubbing or scratching, making the skin appear leathery. Examples include the thickened skin in chronic atopic dermatitis and lichen simplex chronicus, a condition of neurodermatitis. A scar is a permanent fibrotic change in the skin following injury to the dermis. Scars can be atrophic, meaning depressed, like stretch marks or striae. Hypertrophic, meaning raised but confined to the original wound borders, or keloid, which is raised and extends beyond the original wound borders. The final secondary lesion is atrophy. Atrophy is a thinning of the skin with loss of normal skin texture. Epidermal atrophy appears as fine wrinkling, often described as cigarette paper wrinkling. Dermal atrophy causes a visible depression. Examples include striae or stretch marks, the thinning of aged skin, and skin changes from prolonged overuse of potent topical steroids. To put this all together into a diagnostic framework, follow these steps. Step 1 is to identify the primary lesion or lesions present. Step 2 is to identify any secondary lesions that have developed. Step 3 is to describe the configuration and distribution of the lesions. Step 4 is to add other important descriptors like color, border definition, size, and how they feel to palpation. For example, the description multiple grouped vesicles on an erythematous base in a dermatomal distribution points directly to herpes zoster, or shingles. Another example, well-demarcated erythematous plaques with silvery scale on extensor surfaces is classic for psoriasis. Using this systematic terminology-based approach allows for precise clinical communication, accurate documentation, and effective clinical reasoning in dermatology. Thank you for watching. Don't forget to like, share, and subscribe.